Buongiorno signor Presidente, grazie agli organizzatori per l'invitazione. Anche io parlerò in inglese perché è più facile. I will speak about the management of superficial vein thrombosis, and of course in this public I don't have to explain, as we do to the students, how is the clinical presentation of a superficial vein thrombosis. You are all familiar with this kind of pathology. What is important to distinguish is that in these patients there is no generalized edema of the leg, only localized edema in the usual clinical presentation. What is important to know are two things about superficial vein thrombosis. The first one is that what you see clinically often is the top of the iceberg. Sometimes you see thrombosis at the level of the knee, but is still extending already up to the saphenofemoral junction. And you should be aware of this underestimation of the clinical examination. So the second point is also that sometimes there is an associated deep vein thrombosis, and it can present like a kind of a hidden thrombosis, which is not clinically obvious. In French, they have a nice name for that, thrombose muette, which is like a silent occult thrombosis. This thrombosis can have two presentations, either directly extending from the saphenofemoral junction or the saphenopopliteal junction, or even through a perforating vein, which we call percontinuitatem, or an ascending superficial vein thrombosis. And sometimes it can have a floating tail, which can be quite scary when you look at it at a duplex scan. But on the other hand, as the causes for superficial vein thrombosis are always Virchow's triad and are always more or less the same, you can also have non-contiguous deep vein thrombosis. So deep vein thrombosis at another site than the superficial vein thrombosis. This can be at the same leg or at the other leg. The incidence of such venous thromboembolism, because you can also have a pulmonary embolism associated with superficial vein thrombosis, has been described between 5 and 32% according to the study design. So in these cases of superficial vein thrombosis, I am quite convinced, and this is a very important message, that duplex scan is mandatory to evaluate the real extent of the thrombus and to discover any deep vein thrombosis in this patient. You know all these therapeutic measures, which can be very few invasive or more invasive. You can locally apply something. You can do an incision of the thrombus and express the clots. An incision of the veins through the skin is very easy, and it can be very helpful for the patient. Immediate mobilization is important, probably with elastic stockings would be better, so using compression is important. Non-steroidal anti-inflammatory drugs are important measures to take, but no antibiotics. Then urgent surgery, I put between brackets because I am a vascular surgeon and I used to do that, but I stopped some kind of 10 years ago doing so because results are not that good and the risk of deep vein thrombosis is very high. And then, of course, we will come back to that. Anticoagulation is now available for these patients. Instead of doing urgent surgery, we can use low molecular weight heparin. Unfractionated heparin in the United States is more used than in Europe. Fondaparinux has now come up, and also oral anticoagulants. When we look at the treatment, there are kind of two extremes. You have the clear-cut cases, those who have a very limited superficial vein thrombosis, 5-6 centimeters in a superficial trabectory. You can treat them without any problem locally. Maybe you can give some prophylactic low molecular weight heparin, but this is not necessary in most cases. And you can consider planning further treatment of the underlying varicose veins. On the other hand of the spectrum, you have those patients with concomitant deep vein thrombosis. In these cases, of course, you will treat them as usual as a patient with a deep vein thrombosis or even a PE. And of course, these rare cases, often in a non-varicose saphenous vein, These patients sometimes who have an underlying disease like Behçet syndrome or this kind of autoimmune diseases which can present with a superficial vein thrombosis, these need specific treatment, and also this is more clear-cut. You have the not clear-cut cases, and those are the patients who have more or less extensive superficial vein thrombosis in long tributary or especially in the main trunk of the great or the small saphenous vein. What will we do? Will we use only NSAIDs? Will we use anticoagulants? What is the duration of the treatment? What is the follow-up? And what is the cost of this treatment? All question marks and not too many answers in the literature. Let's have a look at some studies. You see here an overview of some studies that have been done with low molecular weight heparin, and basically starting from '94, where they saw a clinical improvement in the study of Titon in France using low molecular weight heparin. The Marchiori study showing that unfractionated heparin with high dose was more effective than with low dose. The Stenock study that showed that initially there was a kind of improvement as to extension of the thrombus, but that the outcome after 3 months as to venous thromboembolism, symptomatic and asymptomatic, there was no difference. Then there was the Vesalio study in 2005, where they saw that comparing a low dose nadoparin with a high dose, 10 days of therapeutic and then 20 days of half therapeutic dosage, it didn't make too much of a difference as to the outcome, but they saw that the events, thrombotic events, were earlier in the group that had a low dose of nadoparin compared to the high dose. And then there is the DAP study with dalteparin, which unfortunately is not yet published. It was presented by Eberhard Rabe at the UIP meeting in Monaco, and again the efficacy of low molecular weight heparin has been shown there. So now recently we have the one study with fondaparinux, which is a very big study. As you remember, the other groups were smaller study groups. Here we have 3,000 patients that have been studied with isolated superficial vein thrombosis, and they compared fondaparinux in the preventive doses, 2.5 milligram versus placebo, and the duration, this is very important to look at, was 45 days. So a quite long duration of the study. The primary efficacy in this case was only clinical endpoints. So you see death from any cause, symptomatic PE, and symptomatic extension of the superficial vein thrombosis. The primary safety outcome, of course, was bleeding. And have a quick look at these results. You see very impressive results comparing placebo with fondaparinux. So it seemed to be effective, and there was no rebound effect after stopping the therapy. As to the bleeding, you see that this was very low. The bleeding risk was 1 out of 1,000 in both groups. Also, the placebo group had 1 out of 1,000 bleeding, so this was not different. You can read all the details in this paper in the New England Journal of Medicine. Looking at the guidelines, which have been published before this Callisto study, the guidelines tell us what I basically told you already, that we don't have too many studies, and that the many studies have no good methodology. There are only few randomized trials, as I showed you, and the basic conclusion was that probably low molecular weight heparins or NSAIDs are the best therapeutic option, and intermediate dosages of low molecular weight heparin for at least a month might be advised, they said. Comparable advices are given by the ACCP guidelines. Also, they recommend prophylactic or intermediate doses of low molecular weight heparin for at least 4 weeks. But you see, it's not really a recommendation, it's rather a suggestion, because it's a grade 2B, and vitamin K antagonist grade 2C can also be given as an alternative. If you want to treat a longer period of time, it's more logical. If you want to treat, for instance, 3 months, then you will use these oral anticoagulants. And what is important also, the last guideline, that medical treatment is preferred to surgical treatment, and I'm quite convinced of that. Of course, an issue is the costs, and it is quite expensive to treat patients for 45 days with, for instance, fondaparinux with Arixtra. So we should consider what is the most important in this patient, and also consider the kind of superficial vein thrombosis. If you have a very small one, let's say 10 centimeter in a tributary, it's not the same issue as if you have a 40 centimeter long thrombosis in a main trunk. So considering this, you use your common sense to decide. So I just go over this last point here because I'm running out of time. What we do about compression in superficial vein thrombosis, there are no data, and I just present you the data that have been presented by Dr. Böhler 2 weeks ago in Prague, preliminary results of a randomized trial to use compression or not in patients with superficial vein thrombosis during 3 weeks. And you see that using a kind of modified Löwenberg test, which uses a cuff around the leg at the site of the thrombosis to see at which level of millimeters of mercury there is pain. You see that there is an improvement in pain in the compression group in the early phase, but over here. But this is not really, doesn't look to be statistically significant so far. And the same for the visual analog score. I am concluding. There are no clear-cut solutions for all the cases. In some cases there are, as I told you. We have low molecular weight heparin, we have fondaparinux. The duration of the treatment will be probably longer than 10 days, maybe 4 to 6 weeks. And surgery will not be appropriate in the acute phase, but can be scheduled later on. But further studies will be needed. And this is what I found in my garden last week. Thank you.